All right, thank you very much, and good afternoon, everyone. Thank you so much for coming. I'd like to welcome you to the Miller G. Deal Cardiovascular Lecture Series. I'm James Harvey. I'm an interventional cardiologist, and I'm the director of the Structural Heart Program here at WellSpan York Hospital. I'm also the new Vice President and Chief Medical Officer for the Heart and Vascular Service Line, which is a real privilege. I'm going to talk a little bit today about advances in the treatment of aortic stenosis, and a little bit about how that might apply to you or a family member or a friend, and what it kind of means and what we can do about it. So the goal here is to let you know about symptoms and prognosis of aortic stenosis, particularly if untreated, and the advances in the management of aortic stenosis, and all here at WellSpan, right here at our WellSpan Health System. I'd be remiss not to talk a little bit about, to give a solid thank you to the Deal family. This Miller G. Deal Cardiovascular Lectureship Endowment started in 1996, and it basically enabled WellSpan Heart and Vascular Division to establish an annual cardiovascular education program for our community free of charge. I often, when I can't overemphasize how grateful we are about that. I always think of the Thomas Jefferson quote when it says, "You're young, and you know, when you're young, you learn that the helping hand you need is at the end of your own arm. And when you get older, you learn that you have two hands, one to help yourself and one to help others." And we're eternally grateful, as are all the members of the community. I also let you know that tomorrow, Dr. Adam Scheib, he was scheduled to give a talk. There were some technical issues. So he'll be talking about some of the hidden signs of heart disease and when you should see a doctor. So let's talk a little bit about aortic stenosis. I will say this, we'll be happy to answer any questions if you type them in. I think the initial ask, unless there's something you really need to know right then, is to put it in there and we'll address all of them at the end. So what you can see here is a three-dimensional heart, and if you remove part of the wall, you can see the heart's a pump. It's a smart pump, and there's 4 valves in it. Now, over the course of our lifetime, the two most, certain valve problems you can be born with, but others you could acquire. And one of the most common ones is aortic valve disease. You can see that's right here, the one going out the big pipe to the body right here. What happens is on the right, you can see this normally opening. It looks like kind of a Mercedes-Benz sign, if you will, 3 pieces of pizza there, and they open up just like you can see on the top. If you look at the bottom over the course of someone's life, and wear and tear and inflammation and scarring on the valve can cause it to become narrowed. So what happens here? It gets calcified. That's when it gets firm and dense. The leaflets don't move. The valve doesn't open. The heart pump, what we call the cardiac output, starts to lower. So the pump isn't able to do its job. Again, you can see kind of a depiction of normal up top and severely diseased on the bottom on the right there. So what happens? For a while, your body tolerates it. The heart's an amazing organ and it can overcome it, but there's a point where the heart starts to ask for help. And this is normally the most common thing we hear is I start getting short of breath, particularly if I walk up an incline, or chest discomfort, sometimes chest tightness, and sometimes people can get actually lightheadedness or lose consciousness, picking up something heavier when they strain themselves. Medically, we have a couple terms for these. We call shortness of breath with exertion because of your heart failure. Chest pain, we call it angina or angina. And lightheadedness or loss of consciousness, losing consciousness, we call syncope. So why are we focusing on these terms? Well, hot off the press since 1968, we've actually known that when someone has severe aortic stenosis and they feel okay, they generally are okay. You can see here, these are people who have aortic stenosis. I'm following this line, and this is a life expectancy. Obviously, as time goes on, certain people will pass away from normal life. But there's a point where this curve drops down, where people's risk of death goes up very high. And this is the onset of symptoms. What symptoms? You guessed it: angina, syncope, heart failure. So if you see your doctor and they tell you you have aortic valve disease, they're probably going to press you. Are you feeling okay? Are you having shortness of breath? Are you having chest pain? And this is the reason why, because we're usually fairly safe until this happens. And if so basically this is the reasons we'll be asking that. So do we have a treatment for it? The answer is yes. We've had treatments for this since the 60s, really, in 50s. The gold standard original treatment for this was surgical, or what we call open heart valve replacement. And you can see a couple of descriptions or animations here on the left. If you look over on the right, this is actually a valve being replaced. You can see the old valve was cut out. You can see all the very intricate work that our excellent surgeons do to put the valve in there, and so it just in position, and it works very well. So what happens? Does it help? Does it stop your odds of dying if you have your valve replaced? The answer is yes. This is data looking at patients who had a surgical valve replacement. You see 2 kind of olive colored lines. You see 2 blue colored lines. And just the dashed and the straight is whether or not you don't have symptoms or do have symptoms. What you can find is if you have severe aortic stenosis and your valve is fixed with surgery, your odds that drop off on the curve flattens out. And so you have a very good survival out to 15 years. However, if you don't have the valve fixed and you don't have symptoms, your survival isn't good. And if you don't have the valve fixed and you do have symptoms, your outcome is terrible. And so we know that surgery actually works. So why do we need to change it? Well, this is a modern day surgical valve replacement. So to do that, yes, you're going to have something that looks a little bit like that. That might be a little bit bigger than what we do right now. And you're going to have a saw that looks like that and something like that. I'm not doing this to scare you. I'm doing it to say that there is a recovery with this. And you can see here that, while some of my surgical colleagues may give me a hard time and say, hey, it's not always that big. That's true. It's not. It's still something that even a fairly stout person may have, it's a little struggle to get by, but it does very, very well. Let me be clear about that. That being said, I have a question for you. Which one of these people you see here is older? Person on the left or the person on the right? That's a trick question. They're the same age, but you can tell here that one person looks probably more frail, and that's a little hard to quantify, but the frail person is probably at a higher risk. In fact, not probably, is at a higher risk for surgery, as opposed to the person on the right there who could probably do a roundhouse kick and would probably fly through it just because of their physical ability and their lack of frailty. And so what does that mean? Well, we've known this for a long time. Our cardiac surgeons know this as well. And so there's a lot of people you can look at and say, yeah, you'd be better off if your valve was replaced. But the reality is you may not be stout enough or healthy enough to have surgery. And this is evidenced by looking at some of our surgical trials that we've looked at for the past, this is up to 2011, actually, when this was published. So this is already 10 years old. But you can see here, the olive color in each of these trials or publications are the patients who did not get surgery, and the people did get surgery, and the blue are the percentage that did get surgery. All it means is if you look at like trials from a decade ago, looking at our surgical data, what it shows is that for various reasons, about half or just over half of people won't be offered surgery. Too old, too sick, too dangerous for that particular person. And so while surgery works, it's not a great it wasn't great for everyone. There was a group of people that weren't able to be treated or felt to be safely treated. So there was a pressure to find a better way or a new way to do this. So a quick thought here, we often think of some, what's the risk of dying, or what's your survival if you have severe symptomatic aortic stenosis and you're deemed not a candidate for surgery? What's your odds of being alive with a diagnosis of breast cancer at 5 years? 23%, lung cancer 4%, colorectal cancer 12%, prostate cancer 30%. Severe inoperable aortic stenosis carries a 3% chance of being alive at 5 years, something we don't think about. So there was a real push to do something better, or to do a new way to help people with this disease. So we all remember the Big Bang Theory episode when Penny was at the doctor's office and she was there with Sheldon, and she said, "Sheldon, the doctor says I need my aortic valve replaced, but I'm too sick for surgery." What did Sheldon say? "Well, Penny, looks like your goose is cooked." She said, "Really?" What did he say? Bazinga. "No, silly, you can have a transcatheter aortic valve replacement." "Oh, Sheldon," and as you know, he said, "we still can die of germs." Now, I'm sure you remember that episode. But fortunately, he wasn't too off, and that there was a strong push to try to find a way to fix these valves without surgery. And so this was actually the first therapy. I won't belabor the details on the trials, but I will tell you that this was a very novel idea. You can see here, this was originally called the Edwards Sapien valves. Actually, Milton Edwards was an engineer, actually worked on aircraft engineering, and helped design this valve with the original first valve with the cardiac surgeon. We designed this valve. It's a valve crimped on a steel cage that subsequently became cobalt chromium. You crimp it down on this balloon. You deliver it through a sheath, usually through the leg vessel, the femoral artery. You deploy it in position. What does that look like? What I'll tell you is this is X-ray. This is actually a real valve that we put in. What you can see here are these, we call them catheters, plastic tubes going up the aorta, around the arch. This is X-ray going through the person's chest. I have a catheter here that's going to take a picture to show the valve because you can't see it. We're going to deploy this valve crimped on a balloon right in the existing valve. So what's it look like? We take a picture. That's where the valve is right here. We're going to pull that catheter up. We're going to take a picture, we're going to inflate the balloon here, just like you can see. That valve is going in, boom, it pushes the old valve against the wall, deflate the balloon, and now you have, a functioning aortic valve, immediately. That's exactly how it does. Immediately, the heart starts to elong. Immediately, you can look at enzyme changes in the heart muscle, et cetera. Immediately, the heart is relieved, and it's a pretty remarkable thing. And so I want to be clear about what we're talking about here. 10 years ago, if you're going to have your valve replaced, it was going to look like this. And now, and this isn't that new, but now it looks something like this: 2 4-millimeter holes, one in your wrist, one in the vein right here, about a 2 millimeters here, 5 millimeters right here. We put the valve in. Typically, you'll be walking in about 6 hours, and not uncommonly, you'll be going home the next day. So when we started doing this, we're treating this a lot like surgical patients. We completely anesthetized them, we put the breathing tube and everything else. And as we got slicker at this and the procedure got better, we realized that the most invasive thing we were often doing was actually putting the patient to sleep with a breathing tube. And sometimes, particularly in an elderly population, that could be, the anesthesia alone can be a dangerous thing to come out from. And so I'll tell you a little story about this gentleman. This was a guy that I met. He was 95 years old, and he had chest pain while chopping wood. I'm not even kidding. So I suggested maybe you shouldn't chop wood, but he wasn't having it. So we ultimately fixed his valve. I was really worried about the effects of anesthesia. And so I'm going to show you a video here. Right now, this is me looking down, talking to him. How are you feeling right now? Good. Your valve is in, and it looks great. All right. Okay, we'll talk in a little bit. So I don't know if you could hear that, but I said, "Hey, how you doing?" He said, "Great." I said, "Good, your valve's in and you're doing great right now." He said, "Okay." Couple things here. One, there's no breathing tube in his mouth. Two, that's about 60 seconds after I put his valve in. So this is someone who was sedated enough to have him comfortable, put the valve in, and then immediately we're waking him back up. And the neat thing about that was the next day I went up to see him, and I walked in his room. And I said, "Hey, how you doing?" And he jumped up, he walked around the nurse's station. I said, "Hold on." He goes, "I'm ready to go home." I was like, "Come on, this is the first time we've done this without the breathing tube." So I said, "Give me one more day, make sure we're okay." And so the next day I went to see him, and I walked in his room and I said, "How you doing?" And he put his arm like this and he challenged me to an arm wrestle. I had a good idea of how that was going to end, so I let him go home, and he continues to do great, actually. So the point being that we'd really changed the game on this, and now I can tell you that about 90% of our patients who we actually do this procedure don't need a breathing tube at all, and the same 90% typically go home the next day. So I told you that this was a new therapy, and the first trial was looking at patients too sick for surgery. This came out in 2010 and 2011. And then and you can see here that the red line, this is your survival, or excuse me, this is death from any cause. Medical therapy wasn't good. You had about a 40% chance of dying. That was cut in half by putting a valve in over 2 years of time. And then we looked at in patients who were high risk for surgery. It was about a tie, maybe a little favoring TAVR, but about a tie. And we looked at patients who were moderate risk for surgery. TAVR came out ahead, which we didn't anticipate. And the same came for low risk. Again, in the right patient, surgery is the right answer, but a growing number of patients can be treated in a non-surgical means. And this doesn't just include the super sick or super frail now, but all the way down to low risk surgical patients who have same outstanding outcomes. So it's really a not so new therapy for aortic stenosis. This wasn't the only valve to come out. Actually, there are several iterations. Another company called Medtronic made a valve called the Core valve. This has since evolved into the Evolute. And there are some favorable features of this that made some of the dangerous anatomy for maybe another platform more favorable for this one. But the thing, I won't belabor the details, but what I will tell you is that there was like any new technology, it came out and it changed the game. And that we had patients who just, when I was in residency, were dying of this disease because we didn't have a safe therapy for them, but now are coming in the hospital and leaving in 1 or 2 days, much better. But like any new technology, it could be tweaked, it could be better. There were things that we still could do better. It was the first wave of this generation of technology. And one of the things I'm proud to say we noticed here was one of these valves had a couple of issues with it. When you put the valve in, there was noticed a higher than desirable leak around the valve. Not bad, but a couple of percentage of people were in danger of a significant leak that does cause problems down the road. Another issue was we found that even in the best trials, you're looking at a trial here where 17% of people who got a new valve had to have a pacemaker. Again, is getting a pacemaker the end of the world compared to not having open heart surgery? Well, probably not, but certainly left something to be desired. Pacemakers can carry their own issues over enough time, et cetera. And even when we look in the registry, the best we'd ever gotten to was about 13%. More than 1 in 10 people who had this across the country needed a pacemaker. And so we challenged that. We said, why is that? We kind of went back to the drawing board. I'm not going to bore you with the details, but this was an anatomy drawing. We actually, our team, in conjunction with a team in Harrisburg, actually looked back to the anatomy lab, said, why is it? We found that the conduction system sits in a certain place next to the valve. We knew that from our anatomy. We proposed, we actually did some experiments to say, on bench models, saying, would this work better if we did a different view? And so actually, we took the standard view. I won't bore you this. This is just a typical CAT scan looking at a three-dimensional reconstruction of that aorta that you see in our aortic valve right here. And this was the traditional view in which we would deploy the valve, but we thought we were missing something. And so again, I won't belabor the details, but we had this theory based on our understanding of anatomy. You could rotate the valve in another direction, better isolate where that conduction system is, and learn how to avoid it in a way that would actually give much less pacemakers, better hemodynamics, and less leak around that valve. Best in class leak is what we proposed. And so we actually took it from there ultimately we were able to tweak this enough to ultimately start utilizing an improved technique that was, actually began to be developed around the country, but ultimately was developed here. And what you can see here is, I won't bore you with this, but basically this is just demonstrating what we did, how we learned to do it. And we looked at we really were doing this very organically. The purpose was to learn to take care of people better, to improve on a technique. And what we found, didn't think we were going to change the world. We just wanted to change how we were taking care of our own patients right here in southeastern Pennsylvania. What we found was that when we looked at our own data over a couple of years of improving the technique, we found that our pacemaker rates were less than 4%, when the rest of the world was around 15%. We weren't the only ones to notice. The industry noticed as well. And ultimately, we were asked to help teach this. And the FDA was interested in our technique as well. And we ultimately have now an international trial demonstrating how to teach this technique, having similar results to what we have found. And this was just a demonstration of a teaching module that we've been asked to teach to places around the country and actually now around the world. The results from this, after we began teaching this new technique to a lot of the places around the country and around the world, ultimately resulted in similar results. We noticed a dramatic decrease in the pacemaker rate across the country. I was lucky enough to present this at the American College of Cardiology last year, where we ultimately found that if you look, the pacemaker rates had gone from around the 20% range down to actually at the Q3 of 2020, we found that the pacemaker rate around the country had dropped below 10% for the first time. And actually, if we look recently, it's dropped down to the 7% range, and this straight lines linearly with our use of with the teaching of this technique. So what can I tell you in conclusion? Well, I can tell you that aortic stenosis is common. I can tell you it leads to significant symptoms, and if untreated, it leads to death. I can also tell you that surgical aortic valve replacement is effective and it improves survival of this disease. I can also tell you that it's too high risk for many people. As a result, the development of transcatheter aortic valve replacement offers a safe, effective, and minimally invasive treatment for aortic stenosis. It's associated with less risk, a shorter length of stay, and a faster recovery. And it's been pioneered by our team in conjunction with a team in Harrisburg, leading to new best practices that have been adopted around the world. I'm very proud to be part of this team. This is a couple pictures of our surgical team right here at York Hospital, our valve team, I should say. We have our heart surgeons, we have our interventional cardiologists, we have an outstanding team of technicians, nurses, OR staff who are all outstanding, echo team, and anesthesia. It's truly a village, and we're proud of our village. This is where we do most of our procedures, right here at WellSpan York Hospital. But I'll tell you that we all, you can see York County. We're proud to be here in Southeast Pennsylvania, but WellSpan's bigger than just York Hospital. We're proud to have some excellent hospitals, which are all part of our system: Gettysburg, Waynesboro, Chambersburg, Good Samaritan, Ephrata Community Hospital. They all have outstanding cardiology groups there as well. When it comes to the valve disease with this, typically they go from there to York. And that helps us to, gain our experience and take care of our patients here. But our priority one is taking care of our own patients here in Southeast Pennsylvania. But our kind of priority two is what we learn to do, how we learn to help people. Our motto is we also want to help people help people. And so not only are we able to take care of patients here, but what we've learned to do, we've been able to help people take care of their patients around the world. So I'll leave you with a slide. This is just a place. These are places that members of our team, myself or Dr. Benton or other members have traveled to around the United States or had virtual observations either via internet or actually teams flying in to observe this technique. And so we've been able to help we've been able to help people here and help people around the world. So with that, I'll end. Happy to answer any questions, and thank you very much.
Thank you, Dr. Harvey. That was awesome. I did not realize all of these places that you guys have been in touch with regarding this procedure. So that's pretty cool to hear. Everyone's welcome to use the Q&A down at the bottom. You can go ahead and type your message. We'll leave it open for a few minutes because I know sometimes it's a little bit hard to find that box. So give everybody a couple minutes here. You may possibly get out easy, Dr. Harvey.
I love it when you cover a topic so well, there's no questions to be asked.
Yeah, that's great. So let's see here.
Number 30 is Beijing, by the way. And that was trying to coordinate the live case presentation. Yeah, the time difference was really neat, but challenging. So
that's amazing. This is really cool to see. But now I think you had a slide about how many you guys do a year at WellSpan, how many TAVRs?
We're in line to do somewhere around 250 this year.
Wow.
COVID changed everything a little bit. Briefly, we had kind of gone up to, from 90 to 100 and something to 230, and then kind of in line to be approaching 300. We backed down a little bit with the COVID scare, and we're kind of back now playing catch up, actually.
Sure. Okay, it looks like someone did bring a question across. They say, is the minimally invasive procedure done only on patients at high risk for open heart surgery?
So that's a great question. Thank you. And the answer is no. So like any, like any idea that may be a good idea, it really has to be validated before you can implement it or use it in treating patients. And so the original trial to see if this procedure worked was first done in patients who were considered too high risk for surgery. So it was compared to just medical therapy. And not surprisingly, the transcatheter valve approach was dramatically improved in survival and symptoms. But then it was, well, how about compared to high risk patients, moderate risk patients, and low risk patients? And it's been proven to be equal or a little lower risk in each of those populations. And so now it is actually become, it used to be when there was a reason not to do surgery, you did a transcatheter approach. Now more than 90% of our patients, low risk, medium risk, high risk, are treated with a transcatheter approach. So the answer is no, it's not just for high risk patients, but really for all comers. And we base it now on your anatomy. Certain anatomy is just more favorable for a surgical aortic valve replacement. And certain anatomy, fortunately, I would say most of the anatomy is favorable for a non-surgical replacement. So very good question. No, it is open to all risks of people now based on your anatomy, which usually is appropriate for a non-surgical approach.
All right, and someone else mentioned, she said, no question, but I was a recipient of a valve repair due to the congenital bicuspid valve and did not require an open heart, but had a good result. Thank you.
I'm glad to hear that. That is great. And I'll tell you, a lot of what we've learned came from congenital heart disease. And to distinguish the two, and thank you for the statement, the congenital heart disease is something that you're born with, as opposed to acquired heart disease is something that you will develop over your lifetime. And while they're similar, they're often are synergistic on each other. So.
All right, you got a thank you. Great presentation from one of the guests as well. So.
Thank you very much. I can actually stop our share here as well.
Hey, Dr. Harvey. Well, hopefully you can get home soon. And thank you for your time. And thank you to everybody coming out. So hopefully you guys were able to get something from this. So
I do see a last question there. Is this available again?
Oh, yes. So I can answer that one. So we do, because it is recorded, we do plan to put it to the YouTube. I think WellSpan has like a YouTube portal with educational videos. And we also will be putting it on the Heart Month landing page that you might have seen if you go on wellspan.org/heartmonth. All of our educational offerings that we had, anything that we recorded will be posted there as well. And like Dr. Harvey said, there is one more deal lectureship that actually got postponed. It will be tomorrow. So you guys can also attend that one as well. All righty. I think we'll wrap it up there. Thank you so much, Dr. Harvey. Appreciate it.
Thank you all. Thank you. I really appreciate it. It was a pleasure.